Thanks. As we bring our next panelists up, Gary Lichtenstein, David Rubin, and Bruce Sands. David Rubin, hi. I will say, not to put pressure on you, but my favorite comment of all the great questions we got here was it says the ladies were much more entertaining than the guys. Welcome, David. Okay, again, a preview of the questions coming here. 53-year-old female with ulcerative colitis on 6-MP with adequate levels, recent hospital admission with a flare, improved with IV steroids and infliximab at a high dose. Trough concentrations were checked before week 5 that were 0 without any antibodies. What to do with the infliximab or a change in therapy. The second case will be a 29-year-old male with ileocolonic and perianal Crohn's disease in remission for 2 years on adalimumab and 6-MP, and now he's asking if he can stop his medications. A very interesting discussion about how and when, if we can stop any or both of these medications. And then finally, a 46-year-old woman with colonic Crohn's disease lost response to infliximab and switched to ustekinumab. Now her GI symptoms are completely under control, but has joint pain, swelling as her biggest problem. And how can we think about either changing medications or possibly combining biologics, which is something that we need to learn more about. So let's start with the first case here. 53-year-old female with ulcerative colitis on 6-MP with adequate levels, recent hospital admission with a flare, which improved with IV steroids and a high dose of infliximab at 10 milligrams per kilogram. However, trough concentrations checked before week 6 were 0 with no antibodies. So what to do with the infliximab versus a change in therapy? And David, let me start with you. So this is a patient who was sick, IV steroids in the hospital, got a high dose of infliximab, but now has no detectable drug at week 6. Are we moving on from infliximab, or can we keep pushing, and what should we do here?
It's an important question regarding the pharmacokinetics and clearance of infliximab. The clinician here gave a higher dose of infliximab to start off, which some have done empirically without data to really support that approach, with the general idea that this patient who's in the hospital needing IV steroids must have a higher burden of inflammation, and therefore we should start with a higher dose of drug. I will say that I do that. But the issue here is, why was the trough concentration 0 before week 6, so early in the loading phase, before we've even entered maintenance? Somebody was concerned that maybe the patient isn't going to continue to respond or respond at all. It can be for either a very high disease burden and presumably high levels of circulating TNF, and therefore the drug is just getting mopped up, or what we've talked a lot about is whether or not this person's just leaking drug, and the inflamed colonic mucosa is leaking drug into the stool, and therefore they're essentially getting a very expensive drug that is being flushed down the toilet. The question you're asking me is, do you try to give more doses of infliximab? There are a couple of centers that have tried to do this accelerated dosing schedule. Do you throw on another dose early? I would suggest that if the patient's albumin is low and they haven't had an obvious clinical response, you probably won't go down that pathway. Here you're saying improved with IV steroids and infliximab. I would suggest perhaps the steroids are doing more than the infliximab when you have no drug present. And I think it's time to move on and consider other things.
Gary, you've been involved in the development programs for anti-TNFs from the very beginning. Tell us about where 5 and 10 came from, and are we sure we're not missing a higher dose that's necessary for some patients?
So the initial study looked at 1, 2, 5, 10, and 15 milligrams. It was an abstract by Philippe Bert. It was never published as a paper, and that was the dose-ranging studies based upon the pharmacokinetics of infliximab, and it was found that 5 and 10 were good, and that was the least effective dose, and hence the study came with 5 milligrams per kilogram, 10, and in the Accent 1 study was the first large study in Crohn's that was looked at. So that was such that it was linear pharmacokinetics, as all the anti-TNFs were, and it was based on pharmacokinetic modeling, where the frequency of dosing was, and a guess as to where the actual concentration would be that would be effective was thought to be the approach to take, though there was no knowledge as to where to go from there. Okay. It was experimenting.
Sure, thank you.
I mean, Bruce, you did a study where you looked at inpatient UC and infliximab. Can you comment on what that might help us with?
Well, that was the first study with infliximab in UC, and it was in exactly this patient population, IV steroid refractory patients in the hospital, and the doses used were 5, 10, and 20 milligrams per kilogram. So we did go that high. The problem is there were only 11 patients who actually enrolled in that study. It was around the time when cyclosporin had come into vogue, so it was particularly hard to recruit, and all the immunologists told us that blocking TNF wouldn't work at all for ulcerative colitis, so it was stopped prematurely. But suffice it to say, there were patients who responded clearly on 20 milligrams per kilogram. I just can't say if it was any better.
You didn't measure drug levels back then.
I'm sure the levels were measured at some point, but I have no recollection of how that related. And anyhow, there were just 2 or 3 patients per group, so you couldn't draw much in the way of conclusions.
Corey, what's the albumin of this patient?
The albumin's in the mid-2s, so not horrible, but not so good.
Well, it's not.
Not
so
so
that's
good.
a prognostic marker, of course.
That's actually horrible.
Quite
If
poor.
you look at the data for prognosis, based on data with certolizumab, infliximab, and certainly adalimumab, that's the best predictor of response with regards to pharmacokinetic modeling.
So, when I see a low albumin in a sick patient like this, I don't even use IV infliximab in the hospital setting now because of these concerns. Whether the albumin just is a marker of the sick patient and the disease burden, or whether it represents leakage, I still am a fan of using cyclosporin. Now, traditionally, those in the room will know and remember that when you had cyclosporin even as an option, you were going to rely on a thiopurine as a maintenance therapy. So we're set up here to know that this patient's already relapsing through what we're told is adequate 6-MP. So then the question is, well, what's your long-term plan? And the long-term plan in the modern era has been to consider a different strategy altogether. Can you use cyclosporin to induce stable remission and improve the patient, and then bridge that to vedolizumab as perhaps a safe option? And we've done that in a number of patients with success and shared that at these meetings.
Thanks, David. Miguel, what do you have from the audience?
Yeah, so there are a bunch of questions on the levels and why they're low, and maybe I'll start with Bruce and then Gary. Is this a TNF sink due to inflammation? Is it the low albumin? Would combination immunomodulators help? IV albumin? I know I just asked you a bunch of questions.
Yeah, all those things are factors. I suppose you have to throw in the possibility that there was a dosing error and no one actually put the infliximab in the bag, but I doubt that's what
Does that happen at Mount Sinai?
Not often. Maybe someone's siphoning it off and selling it on the black market, I don't know. But that's not a likely explanation. The most likely explanation is any of those things, but whatever the case, the patient has a high turnover of the drug. We think that this is likely to be the case for any immunoglobulin that you give to this patient. And so that means vedolizumab or any other biologic that comes down the road. They're not the same targets, obviously. TNF is not the same thing as alpha-4 beta-7, so maybe there are differences, but my prior bias is that he's going to behave the same if you give vedolizumab, unless you find a way to reverse the inflammation and get it under control. Then maybe the vedolizumab might keep.
I agree completely.
And then Gary, I guess the question to follow up on what Bruce said, would you reload this patient at this point, and would you even use a higher dose? I know we talked about 20, 15. What would you do at this point?
So that it's a question of economics and who's going to pay for it when it gets leaving out of the hospital. 20 mg per kilogram is certainly something we did in the past when we had no other options available. And this is something that the Belgian group presented. The 2 and the 6-week data predict the subsequent levels. So this is, again, linear pharmacokinetics. This person is not going to do well. This person has a higher risk of colectomy in the future based upon all the data we have, CO's data and other data from years past. So I think this is where you have to decide. Is it worth giving cyclosporin, say, after you've given infliximab?
Would you do that?
Well, these are things you have to talk to the patient and communicate. There's a higher risk of infection. We have done that on select populations, but we often say we try not to do that based upon the infectious complications that have been pursued and demonstrated in other trials. One could try the 20 if one had unlimited finances.
We shouldn't, I just have to add, we keep ignoring the fact that we have good evidence, it's not great, but we have good evidence of the utility of cyclosporin in patients who are sick in the hospital resistant to IV steroids. And we don't have all the information here. For example, if the CRP was coming down and the patient was really responding versus just feeling a little bit better, getting hydrated. But we continue to talk about some of these same things, and I agree with the last bullet point there that perhaps when tofacitinib reaches our markets, we'll be able to consider that as another non-biologic option in patients like this.
Very quick question, David. Would you give cyclo to this patient who has a trough level 0 infliximab?
That's an important question, and we've published a case report of exactly that, where the infliximab level was 0, which gave us the confidence to use cyclo. I'll just point out that that's not a perfect marker because we don't know if the tissue level of the drug might still be high, and the patient may still have some immune compromise from that drug. So I'm not here to say that this is all safe and easy, and of course you should be having your surgeon seeing these patients while you're trying to work through this so that you're not calling them on a Friday afternoon when you've decided that everything else has failed.
One point to make on that, this person was on 6-MP coming in. So those patients that are on 6-MP prior and get cyclosporin often don't have a good prognosis. And that's data from your institution, Dave.
Absolutely.
I know that you published with
Before we had veto as a different option, but I do agree with Gary's point that this patient clearly has a poor prognosis. And just philosophically, I'd like to think about a 53-year-old who maybe has had UC for a while, who now has just turned the corner. And we all see these patients. We don't really understand why this happens. But when they come in with an albumin of 2, you know that this is somebody who's high risk, and you should have that conversation.
All right, great discussion. We're going to move on to the next case, but some take-home points that we have addressed, I believe most of these, is need to think about treating to appropriate trough levels and recognizing that certain risk factors are going to predict in advance if somebody's going to need more medication or not. I think considering moving on to a different class of medications, specifically calcineurin inhibitors with cyclosporin or potentially tacrolimus that didn't come up as another alternative. You're not stuck at these high doses. If you're giving infliximab at high doses or even very high doses initially, once you get them under control, and whether it's the protein leak or some other system that's causing that to happen, you can very often bring them back down to normal levels, and it is a more affordable long-term plan. If you are requiring high doses of one biologic, and this came up on the panel, you're likely going to need the same sort of problem with another biologic drug, and to think about how we're going to move on to perhaps these small molecules or different mechanisms. So thanks for the great discussion, and let's move on to the second case here, which is a very important topic and has become even more timely as we think about risks and also costs over time, is about de-escalation, something our patients ask about all the time. So this is a 29-year-old male with ileocolonic and perianal Crohn's disease in remission now for 2 years on adalimumab and 6-mercaptopurine. He's coming into the office and asking about stopping his medications. So can he stop one, both? What are you going to talk to this patient about? And if so, how are we going to do it? Bruce, let me start with you and just think about how you address this discussion when this young man comes in.
Yeah, of course, this comes up all the time. The patients don't like being on 2 different treatments. They would like to be on one if they have to be on anything at all. Of course, they'd rather be on nothing. But I think we can put that to rest, that there is hardly a patient who can be on nothing if they have had particularly perianal Crohn's disease. So that one feature that you tell us about makes this a high-risk patient, and completely stopping therapy would be a calamity. You know, if I were to consider stopping one or the other, my preference would be to stop 6-MP. The side effects are, in my mind, a little more onerous with 6-MP long-term than with adalimumab as a monotherapy. But before we embark on any stopping of therapy, I want to know for sure that this person is really in as good shape as they seem to be. They have to be not just in remission, but really deep remission. They should have endoscopic healing. They should have biomarkers completely quiet. Their symptoms should be completely under control, and then I will entertain it. By the way, before I'd entertain it, I would also be checking drug levels of whichever one I'm not stopping. Most importantly, I would want to know that the adalimumab is in a very robust range, because you can guarantee that when you stop the 6-MP, quite apart from antibody formation prevention, you're going to see, when you stop the 6-MP, the adalimumab trough levels are going to drop a little bit. So if they're already borderline or in the low range, they're going to go lower and maybe go subtherapeutic.
Can you be specific, Bruce, about robust adalimumab levels?
That's a hard one because you'll find all kinds of values in the literature. You will find 7.5 as kind of a goal. So I guess I would like to see 10 ideally before I stop this patient.
Double-digit trough levels. Yeah,
So I'm guessing, Corey, since I've heard you present on this topic before, that you picked 2 years as the cutoff because the lymphoma risk appears to manifest beyond 2 years of treatment. Can you comment on that, actually?
Yeah, absolutely. Just a quick comment that within 2 years of therapy, other than the very unusual occurrences that John Fred was telling us about with EBV negative patients who get exposed to EBV, almost all of the lymphomas that have ever been reported with patients, whether it's standard non-Hodgkin's lymphomas or hepatosplenic T-cell lymphomas, occur after 2 years of exposure to thiopurines. So those first 2 years, I won't say they're risk-free, but the risk is incredibly low, almost unmeasurable, of what the risk of lymphoma would be within those first 2 years of therapy. So the way I talk to patients about this is we need to get you better, and we need to get you better now, and then we're going to have another discussion in about 1 year or perhaps 2 years about long-term management. Remission and getting patients better is goal number one. Long-term management and long-term safety can come a little bit later. So that's why I wanted to bring this discussion out about 2 years.
So I often have to remind patients that they're better because of their therapy and not in spite of it. And usually people who come in asking to stop medicines have experimented or were delayed in filling their prescription and felt fine, which is exactly how they should feel if they're in remission and they miss a dose or a week of their medicines. So the de-escalation discussion is first, confirming deep remission and assessing both disease and drug, like Bruce just said. Secondly, discussing risk of doing it and how you might put the patient back into relapse and what consequence there may be. Thirdly is after you make a decision to drop a dose or drop a drug, having a monitoring strategy. What is going to be your strategy to stay ahead of the disease before the patient has a complication and gets into trouble again? And fourthly, what is your rescue strategy? Have a conversation about it. We might want to go back to the drug we stopped and it might not work. We might want to go back to that drug and you'll have a different side effect. There's a variety of things to take the patient through so that mentally you're all on the same page.
Thanks,
Can I
David.
make
Miguel,
one-
what do we have from the audience here?
So
Sorry,
for
we'll go to
David
Gary.
and then Gary will hear your comments too. But just before we leave David on the deep remission, you talk about histology a lot. What do you want to see on histology? Is that important?
I think that is an important concept. We understand more about histology in ulcerative colitis than we do in Crohn's. I certainly value histologic quiescence as a deeper level of remission, although that isn't validated, so I want to make that clear. And I would do biopsies in the distal rectum as part of my assessment of this patient when I'm assessing their deep remission so that I have a good sense of it. And I'd be less likely to de-escalate in a patient with active inflammation, even if it looked fine endoscopically. So I think that is an important component of this. In ulcerative colitis, we know much more. And in CGH, one of our former advanced fellows published our paper looking at normalization, which has an even better outcome in patients in terms of risk of relapse. And so that's a whole other conversation.
So Gary, you want to make a comment, and then I have a question for you.
So one of the things also to point out to the patient is that there's a dose relationship, as best we can tell, with regards to risk of lymphoma based on 2 studies to date. And we only know that the doses were 100 to 150 milligrams had a higher risk than those on 50 milligrams. So one could potentially say, let's try to lower the dose and meet in between if you thought it was not appropriate and see how they do, follow biomarkers, and then say, this is something that is not going the right direction.
And if you were to stop or lower the 6-MP, because there are a number of questions on that, and he were to develop a recurrence in his fistula, would you put him back up on the dose of 6-MP or start it if you had stopped, or would you switch biologic?
I would at that point think that this is likely a drug level effect. Given what we're really doing in part with the use of the anti-metabolites are preventing antibodies, but also boosting the drug levels. And we know the data with infliximab, at least for fistulas, you need to be about 11 is the best data we have to date. So you really want to be on the upper end of levels and to measure a trough level. And that's really what I would focus on at that point.
I agree with Gary, and I'll point out that in the STORY trial, which was the experience with open-label stopping of infliximab and leaving them on the thiopurine, the way they monitored the disease was fecal calprotectin and CRP at monthly intervals, which of course is not practical in what we would necessarily do, but doing it every 3 months based on the modeling they came up with seems like a reasonable thing to do. If you know your patient makes CRP, it looked like CRP went up at least a month or 2 months before clinical relapse. And if you are confident in a fecal calpro as a way to monitor this patient, and certainly in a UC patient, you can do that with an even greater lead time because it tends to go up almost 3 months before you might see a clinical relapse. And whenever you do an adjustment, whether you're dropping the thiopurine and leaving them on the anti-TNF, I agree with both Bruce and Gary that not only do you want to know the level before you make that adjustment, but I would argue you should check it again a couple cycles downstream so you know what happened to it and you can anticipate a need for change.
So one comment from the audience that I think is important, and actually Silvio alluded to this yesterday, there is the ECHO consensus guidelines on exit strategies in the Journal of Crohn's and Colitis in the August 2017 edition. So the ECHO exit strategies may be good to look up as well.
Great. Thanks, Miguel. Just some take-home points, then we'll move on to the last case here. You've heard this from the panel. Duration-dependent risk of lymphoma is associated with thiopurines, possibly dose-dependent as well, which is interesting. You should be aware of a clinical trial that's happening in Europe right now called SPARE. SPARE is a huge European-wide trial where they're taking patients in remission on anti-TNF and azathioprine, and then having 3 arms. One is continued combination therapy, one is continued azathioprine, and the final is the continued anti-TNF monotherapy. So although clinical trials aren't the end-all in teaching us what to do, it's really going to be the best that we have, and we're going to learn a lot from that study that will probably take a couple years to fully recruit and analyze and report the data. You can consider de-escalation, but as you've heard, you absolutely need to confirm that the patient is in remission and not just symptom-free, really looking hard to make sure that you have them under control. We need to make sure that we optimize the remaining biologic or thiopurine concentrations before stopping that second drug, as Bruce said, robust levels, and then close follow-up after withdrawing a drug, really keeping an eye on them with clinical, laboratory, endoscopic, and potentially imaging as well. So thank you, great discussion over a very important topic. Then moving into the last, you may clap.
I like that one.
Thanks. To the last case in this section about consideration of combining biologics. There are a lot of different ways one might consider managing this case, although I wanted to bring up a discussion of what I consider probably the next frontier in understanding how to use the drugs that we have and will have in the near future. This is a 46-year-old woman with colonic Crohn's disease and arthritis, lost a luminal response to infliximab, but with adequate trough concentrations, and therefore was switched to ustekinumab. Now, her GI symptoms are completely under control, but her joints are causing the biggest problem. So would you consider combining biologics here? Again, there are other ways we could approach this patient, but Bruce, maybe I'll start with you and think about using either ustekinumab or other biologics and putting different drug combinations together.
Well, we have biologic agents now that have different mechanisms of action that are largely non-overlapping, so it's very tempting to think about combining them. Will we get better efficacy? Maybe, we don't know. There really is almost no data about this. Will we see a safety signal? That we also don't know. But if I were to think of combining agents, it might be appealing, for example, to think of an anti-TNF with vedolizumab. The specificity of vedolizumab for gut lymphocyte trafficking means, and the good safety profile means that it'll probably be a safe combination. We don't know if it's going to be a more efficacious combination. Ustekinumab and vedolizumab, maybe that would be a good combination. I'm least certain about blocking 3 important cytokines, ustekinumab blocking IL-12 and IL-23 in combination with blocking TNF. That's a whole lot of cytokines to block, and I'm just not sure we're ready for that.
And everyone in the room is thinking, how are we going to possibly get this approved by insurance and pay for it?
Corey didn't ask me that.
I know.
It's a challenge.
So how do we, Dave?
We either they're not paying attention, or you end up with something where they get approval for example, the IV drug, which is separate from an injectable because you've got hospital-based and pharmacy-based benefits. And that happens occasionally. I think there's some anecdotes. I think the considerations from a disease mechanism point of view are fascinating. But I think in the practical reality of this case, I would end up adding methotrexate and trying to work down that pathway.
So
Gary?
the other issue is to bring up joint pain and swelling can be from many different things. And I think, is this a disease-related extraintestinal manifestation? Is it psoriatic arthritis that happens to be associated with this? Is it another diagnosis unrelated completely, Lyme disease, for example, other things of the nature? There are many different possibilities, so to truly say which one it is critical to help define, and at points, perhaps consulting with rheumatologists to see if this is indeed the case. Because if the disease gets better and the joints still remain actively inflamed, the question is it a extraintestinal manifestation of the disease that parallels the disease? One would argue that it's not, perhaps, or either that you're under-treating the disease and you need to better treat the disease. So I think scratch your head, think about it if that comes about, and think of the potentials. Another thing is Plaquenil is sometimes used in these patients. Areva is another one that's used, and a host of other agents in combination. Though they're not biologics, they're certainly helpful.
Great. Miguel, what do we have from the audience? Thanks, Gary.
So this one, I guess, to Bruce, coming back to some of the combination question, but in a different practical way. In people who are on infliximab, so say this patient where you switch to ustekinumab and you get insurance approval 1 week after the last dose of infliximab. So they're ready to start ustekinumab within, say, 2 weeks of a good trough level infliximab dose. Do you have any concerns stacking? Do you need to wait?
In truth, the clinical trials did require a washout of the anti-TNFs. My recollection is that it may have been 8 weeks or something along those lines. So the clinical trials don't provide any guidance about the safety of that combination. That being said, if the patient is sick and needs treatment, you have to institute treatment. And so we do it, but we watch carefully.
So David, well, actually, let me follow up with David. What would you do in that setting? And then there's some joint pain questions for you.
Well, what happens in the world of trying to get approval for a new drug is you're often delayed by a couple weeks anyway. So there's sort of a built-in washout. But I agree with Bruce that as soon as the drug's available or as soon as my next strategy is available, I start it, and then I withdraw the other therapy. If I'm going to try to treat them with combination biologics, which I do have a few patients with exceptional situations like psoriasis with Crohn's disease that's stable on vedolizumab or some things where I've been struggling to figure out what to do and they're on both drugs, I've just been monitoring them very carefully. I haven't started treating them, for example, with PCP prophylaxis or anything like that. But we certainly need to be careful in these settings.
And maybe, David, just very quick question. Methotrexate, the dose you would use in this patient?
I would start with 15 milligrams orally, but I would, given the fact that this patient has Crohn's and now actual arthritis, not just arthralgias, I wouldn't be shy about going up to 25 subcutaneously.
And would you use sulfasalazine for the arthritis?
I would consider it, and it's certainly reasonable to talk about. It might be the first thing we try as we're moving through this with the patient. I agree with Gary, though. You want to know what's going on with their disease, too. You might be missing some subclinical but active GI problems that you need to adjust. And in that case, going to the metho is going to be a better chance than the sulfasalazine.
Great, thanks, David. And thanks, gentlemen. Just some take-home points for this final case for this panel. There are not yet data to support safely combining biologics and IBD, although there are some clinical trials that are currently ongoing. I should note one called Explorer, which is combining methotrexate, adalimumab, and vedolizumab for induction for patients with Crohn's disease. So we'll certainly learn something from that, particularly focused on the safety. Much more experience with vedolizumab and anti-TNFs, although not quite extensive. Not much at all with ustekinumab and combining with others. And this idea of tofacitinib potentially being a bridge to other biologics, specifically vedolizumab, is compelling, but a very unclear safety profile at this point and more to learn. So gentlemen, thank you for a great panel, and we'll bring up our next surgical panel now.